bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. All right, hello everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centers. And today we're going to be talking about achieving epic benefits at CHEO. Good design is as important as good technology. The CHEO, in this case, being the Children's Hospital of Eastern Ontario and the Ottawa Children's Treatment Centre, and the EPIC being their electronic medical record that they've been in the process of implementing over the last quite a few years in various stages throughout their organization. You may recall a couple of years ago we had today's presenter was one of our presenters, but we had the team from CHEO come and talk about their patient portal to their electronic health record, and that presentation is of course available on the Knowledge Exchange Network if you wanted to go back and take a look at that one. But today we're going to talk about we've got a great presentation today to really bring it to the CAFC Presents audience, the whole concept of electronic medical records, the impact on sort of the frontline clinicians and how to engage frontline clinicians and get them to really see the benefits to their own practice in implementing an electronic medical record and the benefits that they will get from them. So we're going to welcome, it's my pleasure to welcome back once again Dr. James King from CHEO. Dr. King is the Chief Medical Information Officer and is also a consulting pediatrician at CHEO, and he's also an associate professor of pediatrics at the University of Ottawa. As well as leading the design and implementation of the hospital information system, Dr. King also maintains an active clinical practice providing complex care for patients in both the inpatient and outpatient settings. So he really is in the perfect position to bridge the gap between those folks in the information systems department and the technology folks with those folks on the front line providing clinical care. So it's my pleasure to hand the virtual podium over to Dr. James King.
Thanks, Doug, and thank you for inviting me to present today. I'm going to walk through some of the benefits that we've seen with our EMR at CHEO and also talk through some of the design decisions that we made through our implementation. And I'd like to also note Catherine DeLude, who's our human factors analyst at CHEO, who was integral in the development of the design of our implementation, and also the assistance of Chantal Trudel, who's the assistant professor at Carleton in the School of Industrial Design. So today I'd like to talk a little bit about our EPIC story and some of the benefits that we're seeing. It's still early days for us, even though we've been doing this for a while. I'd also like to talk about how good design for the system I feel is as important as good technology, and how we use human factors to optimize the user experience, and then talk about some of our outcomes and lessons learned. And I think the biggest outcome is that when you're implementing something of this scope and depth is make sure you have good guiding principles at the start and stick to them. So I'd like to note that I absolutely love working at CHEO. It's a phenomenal environment for care, and that I've got no relevant financial relationships to disclose or conflicts of interest to resolve. So this is one of the prime movers around what we've tried to accomplish or achieve with our design. And this was a statement by Edward Morrow that the former CEO of Medtronic had told me at a dinner table one night that the real business that we're in while it's an information business, it's not really the ability to move that information. That's really an electronic problem. But the real art of our business in providing care is in the last 3 feet, and that's in the face-to-face conversation. And it's very important as we implement these new technologies and sometimes disruptive technologies that we keep that last step in mind. So we've been on an Epic journey. We actually started with Epic with implementation of their patient access and revenue cycle applications back in 1993. This is our star on the Epic floor when we finished our implementation in 1994. However, we've come a long way since then and really kicked off our major implementation of clinical systems in 2012. We developed a number of guiding principles to help us through this, and there's 3 that I really want to highlight that I think are extremely important. And a lot of this has to do with the culture of the implementation and the project. And the first one that I like is that our decisions are based on the patient as the #1 priority. And I can tell you that a number of times I've had discussions at our organization through the years where the priority has been the individual person or the unit or specialty. And it's been just, I think, the greatest accomplishment through the whole implementation that when we discuss something now that can actually be quite crucial in our workflow is that people say, well, how does this impact the patient first? It's not how does it impact me, but it's how does it impact the patient? And that's been, I think, a real big accomplishment through the implementation. It's patient safety focused. We used evidence-based practice wherever we can, realizing that in pediatrics, sometimes there's not a lot of evidence that's available. And we've always considered the benefits of anything that we're doing within the implementation. So many of you know CHEO, we're a 167-bed hospital. We provide services through the National Capital Region and also Eastern Nunavut. We have about 6,600 admissions and about 175,000 ambulatory clinic visits. But I'm going to show you a little bit deeper as I go through the presentation how we're actually getting more of a sense of the total amounts of activities that are happening. So a couple of things to consider when you're designing stuff is that we're a 50-year-old infrastructure, and I put the sticky notes in Post-it notes because we didn't have Post-it notes to actually help with our design for the original build for CHEO. Post-it notes were actually discovered till 4 years after the hospital was built. The cell phone 7 years after our hospital was built. So those things have to be considered when you're doing a technological implementation. We've been going through our enterprise EMR implementation over a 6-year rolling schedule. And our direction to our human factors team was that we would not do infrastructure changes. We didn't want to cause any harm, obviously, and we wanted to aim for consistency across the hospital so that we would take practices that were usable throughout the organization. We would optimize the user experience, and we would respect those last 3 feet. The other thing also is we've had a number of strategic initiatives during the time period, and we always would align anything that we're doing within the project with our action plans so that we were always keeping in line with the other activities that were happening within the organization, realizing that this was a foundational project, and that a lot of the implementations or a lot of the other projects actually were somewhat focused and assisting us through this. So the 3 things that I just want to really relate is that the first thing is the integration of the electronic health record. I really think that integrated records are really important currently, right at the current time. I've lived through an implementation of best of breed, and it's extremely difficult, and you spend too much time trying to interface the different systems. So actually, it's been transformative to us to go to an integrated EHR. And we use Epic as the hub, and for a number of reasons. We did a very, very careful analysis of different EMRs and what would fit for us. But as a pediatric institution, there is definitely a competitive advantage for Epic, and we're seeing that as we integrate with our partners in Canada and through the U.S. And this is just a schematic to show that we're all in. So we are building all of our applications through running through Epic as the networked engine, and we're also all in with Sick Kids. So we have developed a single instance. We have a single database that we are sharing with Sick Kids. They went live about 10 days ago with their Epic implementation as a big bang. And we've been supporting each other through our builds and our go lives. And our plan for the future is that we will come together and that we will have a single designed system. We already have a number of shared we share our data points as far as the database goes, but we're also sharing both workflows and things like guidelines for how each organization collects principal problems, how we would display results, how we would share order sets and documentation. And basically, if there is a way that we can share, we are looking at how we can make that happen. So we see the integration not just of the EMR itself, but of the whole health system. From our EMR implementation, we've been doing an in-depth analysis of provider and readiness and technical adoption, provider use and satisfaction, patient family satisfaction, and we've been aligning our KPIs with those organizational strategic goals and action plans. We have a very in-depth methodology behind how we deliver our questionnaires and the statistical analysis that we've been doing. And this is all built on a benefits evaluation framework that we had partnered with Canada Health Infoway using our CHEO Next strategic objectives and also the key performance indicators that Epic brings with it. They have a large number of out-of-the-box reports, which require some degree of work and customization, but are a starting place to bring all of these together. There is detailed information on this. I do not have the time to go through it at this presentation through Infoway, and we have an ambulatory program benefits evaluation report and a MyChart patient portal benefits evaluation report. And I would encourage you, if you want to get more information regarding this, to look there. I'll just briefly mention that prior to starting our implementation, compared to 3 months go live, we had a really strong engagement from our users. 98% understood what we were doing, why we were doing it. We saw a significant drop in our users' feeling of how well the system was helping and supporting them at 3 months. By a year, we were back to baseline. And now we've seen a significant shift in our provider perspective so that we include questions in our staff and physician engagement survey, and about 77% state that the EHR is now helping them provide effective patient care. We also looked at patient satisfaction pre and post going live. And interestingly, while our providers felt that the EMR was impacting their ability to provide care, the actual families did not feel that the EMR implementation was impacting the care. And they actually saw a significant increase in the number of people who are engaged in using a computer, but they didn't notice a difference in their ease of talking to the provider during this time period. So they did not feel that there was a gap. And we feel that the way we designed the system was in some ways accountable for that. We've done a lot of work on physician productivity, and this is ongoing. I can say that it definitely takes more time to document, and on average, our sense is that it can add 20 to 60 minutes to a physician's day in general, depending on the busyness of the clinic. As far as impacts on productivity and billing, again, very difficult to say. As we were going through our waived implementation, we had clinics that increased their numbers and clinics that decreased their numbers, and that occurred whether or not we went live with Epic in that particular clinic. It's an incomplete measure, so it's very difficult to state that the actual EMR had an impact on the productivity, because clinics that didn't have the EMR also decreased in their numbers, and clinics that had the EMR increased in their numbers. So what's happening with the information we're getting? So in the past year, we know we've had 145,865 unique patients with over 660,000 total encounters. We also know that about 23% of those patients are accounting for 70% of the encounters. I think that this is really important information, and this is a group of patients that we need to focus on to actually improve their patient experience, and perhaps if we can decrease the number of times that they need to come to the organization, we can actually improve the service that we're providing to them. We know that 53% of the encounters that we're providing care to patients with are occurring when the patient is not physically present at the hospital. These are encounters where a nurse is communicating with a patient, a physician's communicating with a patient, a physician is completing a prescription. We believe that this is a good example of how we're providing care closer to home. So it's not just the registered face-to-face encounters which account for all of the care. We know that about half of the care we provide are occurring without the patient being present. And that's part of one of our values and one of our strategic objectives, to provide care closer to home. We've had over 2 million clinical entries this year alone to date, and that's notes, messages. So we're averaging about 500,000 per month. But even greater than that, if you look at our flow sheet data, where we're entering information mostly from a nursing perspective on our patients, we're collecting 12 million distinct data points a month. By the end of the year, we'll have over 140 million flow sheet entries. These are blood pressures, respiratory rates, and this is all searchable, it's all reportable. So we can get down to a very granular level of the information and the care that we're providing to our patients. We know that we've got about 1,600 patients now accessing their own records through our patient health portal. We have a bed board supporting our patient flow. About 90% of our medications are barcoded using barcoded med administration. We have about greater than 90% medication reconciliation, and we've decreased our medication area errors by approximately 2%. We're seeing timely access to patient results, or people reviewing the chart, and we've got 100% of our orders now being entered through order entry, with about 90% of them occurring by physicians. And we're doing a directed program to try and decrease the number of verbal orders that are occurring, but it's already over 90%, which is quite good. We know we've decreased lab duplicates by about 1 to 2%, and we've seen a significant reduction in our lines of transcription. We've achieved a HIMSS Analytics Stage 6 for both our ambulatory and our inpatients. And HIMSS is a reporting mechanism where organizations can compare themselves to how they're doing with their EMR implementations. Once you get to a Stage 6 or 7, you're able to use, and there's good evidence showing that you're able to use the information being collected on your EMR to actually drive your clinical processes and outcomes. So we've actually embedded, at the same time we've been doing our Epic implementation, we've been doing a significant work on our CHEO works and lean management, and we embedded both the implementation and our lean management together. We have our Sick Kids partnership, which has also been the foundation for the Kids Health Alliance and helped us meet the Patients First eHealth 2.0 hub recommendations from the Ministry of Health. And we're also looking at how we can use Epic to drive our population health and our recent One Door for Care program. So for our benefits realization, we have a very in-depth program that has looked at the best evidence, at our peers, at our advisory board, and we've developed a comprehensive list of potential benefits, but divided them out into 9 areas that we wanted to focus on. This is being led by Tammy DiGiovanni and Ken Farian at our organization, and we've identified benefits owners for each of the major benefits realization categories. We've aligned this with our CHEO action plan, and it's going through rigorous quantification. So we're looking at reducing our adverse drug events, optimizing our lab and medical imaging use, decreasing our order turnaround times, reducing health records expenses, optimizing drug utilization, reducing our length of stay, increasing value-added nursing time, increasing our technical fee revenue, and increasing our clinical research. So we have a document which is developed and shared with our audit and resources committee, along with stories that we're developing with regards to the benefits, and then action plans with each of our benefits realization owners. We've developed a link between our benefits realization and our budget with regards to our expected benefits realizations. And so far, we've been able to meet or exceed our targets. We know in the next few years, we're getting into the more meaty part of the benefits realization. So we're doing our detailed work to ensure that we can meet this. If you look at some of the organizations in the States and some of the data coming out, you can increase your overall margin, hospital margin, by about 6% in the US. The difference is the ability for other organizations to increase its revenue generation, which isn't quite as easy on the Canadian side. However, a lot of the benefits realization for that 6% margin increase is about 40 to 50% is on improved efficiencies. So even that is an incredible benefit for our organization if we can achieve it. This is just a quick graphic looking early days in the impact of EPIC on our transcription. And we know that our transcription costs were increasing on a yearly basis. And after implementation, we saw a steady linear decrease. And by the time we had implemented through our ambulatory, we had decreased about 60% of the total amount of transcription that was occurring. This is an example of our order turnaround time and our benefit statement and some of the milestones, roadblocks as we're working through. This is the plan that our benefit owners would look at. And this would be an example of one of the benefits that we've been analyzing. We looked at our medication turnaround times pre and post EPIC, and we've seen a nearly 90% decrease in our TATs since go live. We've looked at length of stay. We're slightly higher post go live, but the difference isn't statistically significant. We had been doing a number of initiatives around length of stay prior to go live around workflows, but it was reassuring that we hadn't increased our length of stay post our go live. And again, we are tracking and monitoring this quite closely as we feel we can use some of the functionality in the system to help improve our length of stay. And we've just recently turned on one of the functions about setting an expected date of discharge, hopefully to improve our patient flow. This would be an example of a soft dollar benefit realization on the ADE side. So at CHEO, we have about 35,000 prescriptions that are being entered through the system per month, including inpatients and ambulatory. About 20% of these fire a medication warning. So an example of that warning could be a patient getting amoxicillin, who's got a penicillin allergy, and then the warning is shown. Now, you can override this warning, but as soon as you actually sign the order and get to the warning, you have basically two steps that you can take. You can override and go forward, or you can back out of it. If you back out of it, we know that in the last 8 months, 1,502 of our prescription orders had an immediate change of the medication order after the warning was fired. And if you look at the Canadian Patient Safety Institute's report on the economics of patient safety in acute care, they've averaged out the cost savings from a prevented medication error. And we would be saving a minimum of about $700,000 to the healthcare system and as high as $6 million if an adverse event is prevented each time one of these medication error orders are changed. Now, that's not necessarily a savings for us, a direct savings, but it's definitely a health system savings, and it's a better care provision for our patients. We're also looking at the efficiency of closing our encounters. This is an older graph. Our numbers have increased to about 90% right now. Our goal is to have 90% of our encounters closed within 7 days, and we're pretty close to achieving that. That's a pretty good rate compared to how other organizations have reported in the literature. Finally, just a couple of quick notes on our patient portal. So this is definitely another benefit that we're achieving. So we have a tethered patient portal. We're linked with Sick Kids. A patient at Sick Kids or at CHEO or shared between the two organizations would get results coming from each organization into their MyChart. It's a very slick setup. It's tethered and exists inside of our server, so it's completely secure. The patient gets, or the proxy gets, a tickler message stating that there's new information, and then they log into the secure server to see their information. At CHEO, this is a recent activity encounter that we are looking at. And just to highlight a couple of things, we're seeing slow growth in our MyChart activations. Certainly not as fast as we thought, but we are seeing growth, and we are looking at ways that we can encourage more people to join. There are a few areas where we have not had patients that have activated, and in some areas the activation's been quite good, such as complex care, where 43% of our patients are active. We do two-way messaging. We've been rolling this out through select clinics, and their feedback has been quite positive. We have about 700 messages now that are being exchanged per month, and that's doubled over the past 6 months. Messages to providers are read quickly, usually within a day, and we have an equal proportion that originated from the team versus the family. So this is the team reaching out to the family versus the family asking a question. And it's a very slick system because it enables one to connect without doing telephone tag and to keep a record of those connections. We did a patient family survey, and it was overwhelmingly positive. I just want to highlight that about half of the people surveyed felt that they avoided a call to CHEO based on the patient health portal. About 30% avoided a visit, and about 76% felt that the portal helped them prepare for the next visit. And certainly the feedback that I'm getting, though anecdotal, is that our physicians feel that their patients coming in that are on MyChart are better prepared, and that the clinical visits are much more efficient. I just want to make a quick comment that one of the challenges we've had both institutionally and with our shared instance with Sick Kids has been around mostly privacy. The security part's been very straightforward. But we are living in a bit of a Victorian age with regards to privacy for some of the information and sharing. And our current privacy legislation, which I believe was developed in 2004, has not kept pace with the current technology and our ability to share information and expectation around our patients for sharing this information. I'm just going to switch gears and talk a little bit about our human factors and how we set this up and how we ran through it and the benefits that we saw from it. So I'm going to talk a little bit about our study context, approach methods, and some of the outcomes and challenges. So human factors is basically the ability of looking at what are the different environmental, physical, human factors that help or hinder the performance within a system. This is, I love this slide. This is had always been a challenge for me. I could never figure out in an oven or a stovetop which control was which burner. So the left-hand side would be a poorly designed system, whereas the right-hand side makes it quite evident without labels being required for turning the oven or the stovetop on. So basically, prior to our implementation, we realized that there were interactions and workflows involving human-to-human, human-computer, and human environment. And we wanted to look at how we would improve and optimize our end-user satisfaction with our EMR implementation by taking these into account and how we could actually provide a better experience. So within our EMR journey, we were basically had two primary waves. We had an ambulatory wave and then a big bang core implementation. So we started our human factors involvement on the ambulatory side. First thing we looked at was factors in situational awareness. So this is an example of the header that we show within our EMR. It's a 24-inch widescreen display. We have a standardized header across the organization for clinicians. And basically, from the far left, we have identification, so you know who the patient is. We have our clinical information, so you can get a good heads up as far as what the things are that you need to know clinically about the patient. And then we have all of our alerting that occurs on the right-hand side. And this is standardized so that if you're looking at this as a neonatologist or if you're looking at this as a nurse on the inpatient units, that this would be presented in the same fashion. The other thing that was a big, a lot of feedback about concerns from our providers was system access and timeouts. And this is an extremely complicated and challenging thing to work through. So we did an ethnographic study involving with our human factor specialists involving a number of clinics, and we standardized our IS timeouts across the organization without an impact on policy. So this was value added work. And then on top of that, we looked at adding tap access, which has been really made a significant difference on our end users' happiness and satisfaction with the system. So for our human factors assessment, we would start in a clinical area with interviews and observations. There would be scenarios and task analysis done, analysis of the environment, computer interactions, human interactions, and then a participatory co-design stage where people would design out what they thought was the optimal way. And then a gap analysis to look at, what our current and future workflows would be like. We did simulations around each of the different workflows and then recommendations to provide the gaps. And then we implemented it. And then we did an iterative cycle to go back and repeat this as we did our different implementations in different areas. So this is just a quick example of some of the contextual analysis that was done where we had a human factor specialist in following someone in a clinic and observing the different workflows. And from that, we were able to develop a cross-organization requirements about patient information, line of sight, privacy, clinic coordination, and shared awareness. We then were able to map this with the devices that we were using so that for patient information, basically any of the devices that were available could work. For line of sight, specific devices would work. For privacy or clinic coordination, again, you would have specific devices. So these requirements we developed showed a hospital-wide consistency. So there were requirements about before you would see the patient, during the visit, in consultation with providers, and closing the encounter. And there were similarities with three major visit types in the ambulatory areas: an office visit with an exam, a procedural visit, or a counseling therapy visit. We found that there were reusable hardware recommendations that would support the clinic work types depending on the visit type. This allowed traceability for us to justify the hardware selection, and it allowed proactive identification of workflow issues and recommendations to deal with them. And we deployed this in an iterative process across 73 specialty services. So here's an example of our implemented solution. So in the ENT clinic, in general, there is requirements in the outside the clinic rooms for patient information, line of sight, privacy, clinic coordination, and shared awareness. And this was basically on the left-hand side, the before, how the chart would be used as a visual cue that the patient was ready. And then we moved to a wall mount computer with cues within the computer themselves that could lead the clinician to knowing that a patient was ready to be seen. This is an example in a procedure room where patient information, privacy, and line of sight were most important. This would be the current office setup, and then the changed office setup where we had a sit-stand station, which would allow that line of sight and also be able to turn the computer to allow that privacy if required. When we went to our inpatient and emergency areas, we knew that our requirements would be different and that they may not be transferable. And then we had concerns with the older existing infrastructure and some of the hardware we had. So we used our guiding principles and revised them to be appropriate to the inpatient and ED work. So we targeted workflows, again, that had hospital-wide practices. We focused on documentation and review for patient assessment, procedures and interventions, handover, medication administration, and the admission, discharge, and transfer processes. These were our primary things that we focused on. And then we did deep dives on the inpatient medicine, inpatient surgery, and emergency units, and then gap analysis on the remaining units. We partnered with Carleton University to augment the human factors and design resources. So we were on a budget, and we were trying to actually maintain a couple of things. One is to do it within our cost, and also to provide an academic flavor. We are an academic institution, and we wanted to make sure that we were doing this with a certain level of rigor as we did the design process. So we did our technology assessment, looking at our hardware and devices. We then did our observations and did our focus groups and interviews, and they were followed by simulations. So I'll just walk through a couple of things. The technology assessment looked at all the different devices that were available and did a deep dive into looking at key characteristics for them. We did site visits to other organizations to see how the facilities implemented and supported the hardware. And then we added the device types and configurations to meet the needs identified during and after the observations, similar to what we did in the ambulatory area. In our observations, we did about 20 hours per unit on the focus units and 4 to 6 hours on the other units. And there's a schemata on the right-hand side of the what was coming out of the observations. We had diagrams of the different units and where the areas were occurring. And then we looked at all of the different spatial interactions, the interactions from a human environment and human computer perspective, what locations where these would occur, what the artifacts were, and the behaviors around our staff and patients. We then did focused groups and interviews where we walked through each of the different areas and looked at where everything would be from a technological perspective. And this provided really good insight on where we really needed to focus, because our focus groups were able to bring out where some of the pain points were. We used all of this to go through a co-design phase, and then we simulated with mock-ups of the different patient rooms and the test hardware. So in the co-design phase, again, we drew out based on the location maps for the areas where the different technology would sit. And then this is an example of co-design for a foot wall. So we mocked up what it would look like for a foot wall that would be in a patient room, of where the computer would be, but not just the computer. You can see we're also looking at where the other things such as the wipes, Purell, and sharp spots would be in comparison to how it would be contiguous to the computer. We then simulated this in a patient room, brought in a number of different providers, physicians, nursing, allied health, health professionals, and then sort of walk through the different devices and did these simulations in a real context, how you would do a rounds, how you would do a patient assessment, how you would deliver a medication, and using each of the devices to walk through each of those different steps. We then mapped this out, so we did a setup for the clinical documentation rounds in ASAP. On the left-hand side, ASAP is the emergency application, and then we did this similar setup with the inpatient unit. So this is the design proposal for our foot wall, and then this is what the actual foot wall looks like. So looking at what the available technology was, to naturalistic observations of how people were using the system, how they would future use it, to a co-design, to a simulation, where we mocked it up, to the actual drawing, and then to the real design for the foot wall. So interestingly enough, while I mentioned that we felt that the ambulatory requirements weren't transferable to the inpatients, 4 of them actually were, and were brought out quite quickly. Patient information, line of sight, privacy, and shared awareness is as important on the inpatient side as it is on the ambulatory side. Though we developed or identified 4 other requirements, the need to support infection prevention and control was highlighted on the inpatient side. And again, I think this is partly due to the acuity and the frequency and rapidness of some of the assessments and the need to clean or support cleaning equipment. The ability to log in and out of the EMR quickly was more of a requirement, both in the emergency and inpatient units. Ergonomic features and postural supports when you're standing all day and moving around in an inpatient unit is quite important. And mobility and context were also quite important as well. So having devices that were flexible and mobile were seen as important. So that was taken and all of those requirements were put together similar to the ambulatory side. And then these were mapped and drawn out on a design plan for each unit. So our analysis across our inpatient units revealed, again, hospital-wide practice requirements around very specific things for documentation, review, and orders, medication administration, admission, discharge, and transfer. I think that these are generalizable things, and the information that we've gained from this deep dive into this is applicable to other healthcare pediatric organizations. Again, similarity by the visit type or the work type in rounds, procedures and interventions, and handover. And it led us to having these reusable hardware placement recommendations. It again allowed us the traceability for justification of what we did, the proactive identification of the workflow issues. And then these solutions were deployed across our 9 inpatient units, including our pediatric and neonatal intensive care units, our emergency department, and our medical day unit. So some of the lessons learned, the first is engaging our users in the requirement and design facilitated a lot of collaboration between the clinical users, sharing space. Like a number of organizations, we have many people using similar space, and this allowed a good understanding of how the space was being used and what the future projections for the use of the space would be. It enhanced our understanding of complex workflows and how we could actually proactively mitigate those. The guiding principles led to equipment installations that supported our end user workflow in both of our inpatient and outpatient contexts. Mobile devices in fast-moving dynamic workflows were quite important. But one of the difficulties is the EMR interface is not always designed with this in mind, and you need to keep that up front, because if you try and use, so we have a mobile device application that works very well with the EMR application. But if you try to actually show the full screen, the 24-inch optimized EMR on an iPad, on an 11-inch or 9-inch screen, it just doesn't work as well. So the interface has to really be thought through as you're developing your mobile devices. And we feel that the application of our human factors methods, it does take expertise and resources, but it adds real value. And I'm convinced that a number of the benefits that I talked about earlier are a result, and our ability to get our clinicians as engaged as fast as we can are a result of having the system designed with them in mind when they're actively using the system. And it I think helped us keep in to bridge that final 3 feet, and to allow our providers to know that we really wanted to keep the patient interaction at the forefront. So designing an integrated EMR CHEO, if you look at a mobile device, the cost is about $1,000. Our physician training total cost per physician, probably about $6,000. However, if I can get a high functioning orthopedic surgeon running a hot clinic, seeing 80 to 100 patients, documenting and putting his orders in and being complete by the end of the clinic, that's priceless. Thank you. And I'm happy to take any questions.
Oh, absolutely. I'm sure there will be lots of questions. That was a fantastic presentation. I mean, you covered a ton of ground, but really articulated it so well, really laying out the benefits of the technology and what the record can bring, but also the importance of those human factors and the physical environment, et cetera. I mean, that was really a great presentation. One of the questions that came in early on, I'll just sort of go back probably about halfway through your presentation. You were talking about some documents around that you prepared. I think you mentioned it was for an audit that listed the benefits of the implementation, et cetera. One question was asking if those were available anywhere on the website, or if that was just sort of for more internal purposes.
That's more internal purposes, but if someone wanted to email me, and my email is there on the document on the slide, I can connect them with our leads for our benefits realization, and we've been quite open to sharing just about everything that we've been doing. One of the major benefits around this particular EMR vendor is they connect us with other organizations, and those other organizations have been phenomenal at sharing what they're doing and sharing their processes. So we've really engaged in that, and I think that for us as healthcare providers and organizations, the only way to move the dial on this is for us to actually share this information. So I'm happy to connect people for that.
All right. When you were going again earlier on in the presentation, you were going through some of the numbers around the electronic health record, and you were talking about the sort of the number of data elements that you've been collecting. I think you said something about 12 million elements when you were talking about sort of blood pressures and respiratory rates and that sort of thing. I mean, that's a fairly significant number, particularly when you also mentioned that you've combined this with the data from sick kids in a shared record. Is there any opportunity there to start applying sort of big data or artificial intelligence to that, to start looking at trends and patterns and that sort of all that promise of the big data, always talks about, being able to identify things once you get that massive amount of data? Is there any discussion about applying some of that to the data that you've got now?
Yeah, absolutely. So we're having those discussions right now. We're hoping in partnership with Sick Kids. They are very early days in their go live. They are doing a lot of their break fix management. And then as they sort of come up out of water, and get the system stabilized, and they're doing an amazingly good job so far with that. It's incredible when you look at the depth and scope of what they've done with a big bang implementation across the organization. But it does take a little bit of time to restabilize. We definitely want to look at how we share our business intelligence and our analytics, especially around the big data piece. The other part that we're quite interested in is how do we develop this into a learning health system so that we're sharing together with our partnered organization, but other large organizations like CHOP, Boston Children's. How do we actually connect with all of these different organizations? And we just had Chris Forrest here from CHOP, who's part of PedsNet, and certainly in the future, that would be one thing that we would be quite interested in pursuing and seeing how we can take advantage of that.
All right. The next question came in from Brett. He says, great talk, and the data on adverse drug events was very interesting. He says it's his understanding that CHEO has recently joined Solutions for Patient Safety, or SPS. Has CHEO been able to, or believe it is possible to, leverage any of the standard EPIC reporting to submit data on SPS hospital-acquired conditions, for example, central line-associated bloodstream infection, pressure injuries, falls, etc.?
Yes, absolutely. So in our action plan, one of the safety part, one of the items out of that is SPS, and we have a detailed work plan incorporating EPIC and aligning with Sick Kids, who are a little bit further ahead of us in their hacks with SPS. But we are definitely going to leverage our EPIC reporting to help with that and with the workflows around. I think CLABSI and VAP are two of the top ones that we want to start with.
All right. The next question is sort of part of, I think, of a larger question that many might have, and especially anyone who's gone through the process of implementing a health record. There's often concerns from the staff about the change in process around entering and documenting and that sort of thing, as being anytime it's a change, it ends up at least initially being more work. So the whole question around workload from the staff, and this question in particular was also asking about workload associated with MyChart. She says there's a great deal of apprehension from some staff around increased workload. So that, again, along with the change and documentation and that sort of thing, also with MyChart, the patient portal, questions coming in from patients who are accessing their record. Anything you can talk about as far as, addressing those kinds of concerns from staff?
Yeah, so I would say from the EMR documentation itself, and I mentioned this, there's a definite increase in the amount of time for documentation, especially if you're not in the system all the time. So things that are very, I mentioned our orthopedics, high volume clinics, you get very good, you can template, and you can collect the information very quickly. In more complex, lower volume clinics, it sometimes takes a little bit longer. And this has been a bit of a challenge because we want to give tools to allow our clinicians to document quickly and efficiently. And those things are like using front-end voice dictation, which we're doing. We use Dragon Medical One. It's worked seamlessly with, you can do it either through a microphone or through a mobile device or your phone. And that's been quite helpful. But if you're typing and it's new to you, it definitely increases the amount of time. And there's also a number of administrative pieces that people are capturing as well. So we're trying to streamline that as best as possible. So from the clinician side for documentation, for sure, there's more work. I would say that from the MyChart side, there's definitely significantly less work with the two-way communication. Now, we don't have patients communicating directly with physicians. We have them communicating with their care facilitators, case managers. So there's a bit of a line between. But those care facilitators and case managers, they were actually doing that communication before, and often by telephone. And we've seen decreases, and this is in our consumer health report that's on the InfoA website, with the amount of time it takes to communicate. And it's a much more efficient way and a much more complete way of communication. Because you can imagine in the past, you had to have a telephone connection. You had to actually get the person. So sometimes there's 2 or 3 calls made. You have to write the information down, and then you have to get it into the medical record. You have to call for the chart. There's a whole bunch of things. Right now, through MyChart, the question comes in. It's already electronically formatted. It's already in the chart. You just reply back to it and send it. And there's an acknowledgement from the family when they receive it. You know that they've got the message. And so it's significantly better through the patient health portal. We did a lot of education for our providers, and there were a significant number of myths and misperceptions on the sharing of information and the impact. And I would say, there are some things you have to be very careful with when you're sending the information out for results for very sensitive, critical things. But by far, MyChart has been an incredible benefit for sharing and engaging our patients with their information.
All right. The next question is from Mark, and I'm going to try and interpret his question a little bit. I'm not exactly sure I think I know what he's asking, but Mark, put a follow up in if I've misinterpreted your question. But he says first off, he says so many questions, he just has to pick one. But he says, what percentage of clinical pathways were, and he says Ontario built versus Epic. So I think he means how many of those clinical pathways, what percentage did you have to develop and input into the system yourself or build in some way within the system versus what might have been out of the box built into Epic?
Yeah, so great question. We've had an incredible journey through this. So starting off, there's now an Epic Canadian Foundation system. And when we started on this, there wasn't an Epic Canadian Foundation system. There was a thought from Epic that they could implement an Americanized system in Canada. And we've been, and other organizations like Women's College have been extremely helpful with this, and Mackenzie have been helpful with this as well. But we've been shouldering a lot of the burden with the Canadianization for Epic. And that's in a number of different components, just how things work and how the system is set up to help organizations meet meaningful use criteria. So there is a significant amount of work done on that side. From the actual templates and that come, there's a lot, but you have to do a lot of work and a lot of configuration. It's not customization. You don't have to touch code and that, but you do have to configure it. And you do have to sort of get it to align with the different workflows and the different reporting structures and systems that we have. And things like, doing CTAS, the Canadian Triage Acuity Score at the emergency department, getting that aligned so you can capture that information, which needs to go to Cancer Care Ontario, and doing that within the workflow of the nurse who's trying to triage sick patients and stuff. So all of those things had to be configured on our side. So, our team would be probably 60% CHEO and 40% Epic with regards to a build around a particular template.
Next question. We've got about 3 more questions. We have 1 minute left according to our scheduled time, so hopefully we won't go. We'll just maybe be a minute over our scheduled time. But Jeanette's asking, are you using any registries for certain patient populations? So within the medical record, is there the opportunity to sort of group patients based on a diagnosis, for example, and get sort of the benefits that a registry, like a standalone registry, often gets as far as grouping patients and analyzing data in that sense? Is there the ability to do that within Epic?
Yeah, absolutely. And it is designed to enable any registry that you want. We have a large number of different registries that we've built within Epic. We've got a large number of automated reports that were being done previously, like around diabetes, that were being manually done, that are now automated through the system. And we just built an asthma care plan with an asthma registry, including a patient-reported outcome that could be delivered through MyChart or delivered through a mobile device. And we built that registry ourselves.
She's actually just put in a follow-up. She's wondering about specifically congenital heart issues. Did you do anything with that?
So I don't believe we've got a congenital heart registry, but if we have the requirements for it, it would be easy to build.
All right. Just a couple more questions. So the next one is saying, it's sort of along the lines of the clinical pathway development process that you described. So you may have already answered part of this, but she's asking, when looking at required data elements, did you use a care pathway approach to determine start to finish data requirements, or do you have other suggestions about how to match the documentation with the patient journey?
So we would use a care pathway, it depends on whether you're in an ambulatory or an inpatient context. So you can build them separately. Epic allows you to build these very detailed smart sets in an ambulatory perspective, or you can build order sets on the inpatient side. A couple of the steps that we would use if we're building something is we have a number of organizations that we connect with in the US. We would reach out to one of those. So Epic has a community library that they share. So you can search any hospital that they're involved with and any of the pathways that have been developed to get an example of what's out there. If you find one that you like, or we would look at certain organizations, we would then call the person who actually was responsible for developing it at that organization, and then gather the requirements from our provider and look at what we had sort of out of the box, and then what another organization had built, and then try and build a single best practice around that.
All right. We did have a question asking about the opportunity to see this webinar, the recording of this webinar after the fact. And I just wanted to mention before we get to our last question that yes, we do record these webinars, and we will make them available on our Knowledge Exchange network after the presentation. Usually takes a couple days to get those recordings up. The last question is around one of the areas of interest for CAFC over the last number of years is around transition to adult healthcare services for children with chronic health conditions that receive pediatric care and then eventually have to transition to the adult system. Is there any existing hospitals that, like, you have this great project with sick kids sharing data between two hospitals and helping transition patients that may move back and forth between sick kids for particular procedures, like rare surgeries and that sort of thing that often happens. What about the adult sector? Is there anything within Ottawa, within the Champlain-Lynn, the region that CHEO is in, for those of you not from this part of the country, or across any other adult facilities throughout Ontario? Is there any plans, any opportunities to work with an adult hospital using Epic to ensure that smooth flow of information?
Yeah, so we built a transitional plan within the EMR that guides the physician through all the required documentation they should be putting together, like a care pathway, I guess. So one of our physicians has expertise and helped design this. But the Ottawa Hospital, which is our large regional adult hospital, is right in the middle of their Epic implementation. So we will be sharing information Epic to Epic. It's not the same as what we can do with sick kids with the same database, but Epic has tools, Epic Care Everywhere and Epic Care Link, that allow you to actually share a complete record between two organizations. So we'll be able to take our transitional planned documentation, put that together, and just seamlessly share it across to TOH. And the plan is they'll be live by this time next year.
All right, well, that's good. That's good. Lots of great opportunities in the future there then. So I think that's it for the questions that we have. We are just a couple minutes over time. Any closing key messages, thoughts you'd like to leave the audience with before we wrap this up?
Sure. I think integration is key. From an organizational perspective, it's really important with the integration. The other thing to keep in mind is I think that this industry will go through some disruption in the future. Not sure exactly when, but it's a very insular application right now. So I think, stay tuned. It'll be interesting to see what happens. And then the connection and the culture piece is quite important. And if you design things really well and focusing on the design can really help improve how people adopt the system.
Well, thank you very much for that. And if people do want to get in touch with you, we did have your email address up. I believe it was king@cheo.on.ca, or was it jking?
No, I'm the king at CHEO.
Yes, the king at CHEO. All right. It should be easy to remember. All right. Well, thank you very much. And we at CAFC, we have, I think, maybe even more than the folks at CHEO have been impacted by this implementation. I know you always did your rollouts in October, right around the time of our annual conference. And there was always lots of very sad people at CHEO who weren't allowed to come to our conference because they had to be on guard for the big rollouts. So hopefully that's over and the folks from CHEO can now start coming to our be free to come to our conference.
Awesome.
All right. And with that, we will wrap this up. So thanks again to Dr. James King from the Children's Hospital of Eastern Ontario and the Ottawa Children's Treatment Centre. Great presentation, lots of great discussion from our audience. As you know, that when you do watch live, we do our webinars every Wednesday at 11 a.m. Eastern Time. And when you are here live, you do get to participate in the discussion and ask your questions and put in your comments. But when we can't, as I just mentioned a little while ago, we do record all of our sessions and make them available after the fact on the Knowledge Exchange Network at ken.cafc.org. And as I did just mention, we do have our annual conference coming up. If you just go to our website, we're slowly getting the information up. Registration should be open in the next couple of weeks as far as our conference. Our poster session is closed, so you did miss the opportunity for that. But our conference is October 21st to the 23rd in Edmonton for those of you who are interested in that. Our next webinar next week, and which is actually our last webinar before our summer hiatus on June 20th, we'll have the Coach Approach, supporting families of children with disabilities. And this webinar is brought to you by our colleagues from ChildBright, which is a pan-Canadian network that aims to improve the life outcomes for children with brain-based developmental disabilities and their families. And this presentation is going to showcase 3 research projects funded by ChildBright that use a coach model at 3 transition points in a child's development. So a great presentation next week, as I mentioned, our last one before our summer hiatus. So hopefully we'll see everyone back here next week. Otherwise, thanks again for coming today. Bye, everyone.